running a little bit late. I want to welcome commissioners and members of the public. This is yet another remote-only commission meeting. I keep saying that I hope this will end. The numbers don't look good in that regard right now, but we can always hope heading into the holiday season. Given that this is a remote-only meeting, additional ground rules will apply. I'll begin the meeting with a roll call. During the meeting, I'll ask that people speaking identify themselves before speaking. That way, commissioners and members of the public will know who's speaking and have the same knowledge as if the meeting were being held in person. We're using the Zoom format today. All commissioners are able to unmute themselves at any time and may speak.
Yeah.
Okay.
That
Right, so put emails in.
please mute themselves throughout the rest of the discussion so that we don't get background noise like we just had there. For this meeting and other future remote-only meetings, we'll post documents that'll be acted on or discussed at least a day in advance so that members of the public will have time to download them and to digest them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. Excuse me. I will now call the roll. Commissioner Akintate. Bim, are you there? I don't think I saw him before. Okay. Commissioner Bandari. Dr. Bandari, no. Commissioner Boyer, I see you there. Commissioner Boyle.
Here.
There you are.
Mhm.
Commissioner Brumbaugh.
Here.
Great. Commissioner Cheatham. I heard you loud and
Hi.
clear. There you go. Commissioner Dorden.
Yeah.
Yep. Commissioner Jensen.
Present.
Commissioner Metz.
Yes, sir.
Commissioner O'Connor.
Here.
Great. Commissioner Reimer.
Here.
Commissioner Sargent.
Hello, I'm here.
Commissioner Wang.
Morning for duty.
Great. So the only missing then is Akintate and Bandari from those that we were expecting. All righty. Included in your packets are copies of the minutes from the November 18, 2021 public meeting that took place in person and by video conference. I'll entertain a motion to approve those minutes.
So moved.
Second.
So motion by Commissioner Jensen, second by Commissioner Boyer. Is there any discussion? Great. All in favor?
Aye.
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 Any opposed? Great. Item 1 is passed. All right. Item 2 is an update of activities. Before we begin with the agenda today, I want to note that this is Commissioner Reimer's final meeting. As you may recall, Commissioner Reimer served as the reviewer on a complex organ transplant review in Montgomery County in 2020. For that CON application review, she carefully considered the evidence, listened to the applicant and to the interested parties, and produced a well-reasoned decision. She has also been a regular contributor to our discussions and I would say a thoughtful contributor who has added valuable insight on a regular basis. I want to thank Commissioner Reimer for her service to MHCC and I wish her well in the future.
Thank you very much. I'm really going to miss everyone, and I appreciate all your support, and I really enjoyed it, but I will certainly keep track of what's going on because certainly healthcare in Maryland is very important to me. So thanks again, and I hope everyone has a wonderful holiday. Thank you.
Thank you. Commissioners have received written updates from our centers. Commissioners, do you have any questions on the written updates?
Yeah, I do.
Commissioner Boyle.
Yeah, I'd love to have some comment from Ben about the pending notices of acquisition, change of ownership on the North Oaks continuing care retirement community.
Thank you, Commissioner Boyle. So this has been a issue that the commission has discussed internally, met with our other state Department of Health partners at MDH, as well as Department of Aging. Our role here is focused on the comprehensive care facility at North Oaks, which is a continuing care retirement community in Northwest Baltimore. And we are aware of some of the characteristics of the acquisition team, but our role is to simply conclude whether a CON is needed for this acquisition, given what they propose to do with Autumn Ridge, the nursing home at North Oaks. The indication is that the services offered at Autumn Ridge will not change. So our ability is limited under the current statute. The characteristics of the ownership group have been observed, and we did share our communication with our partners that should this ownership group seek to establish a comprehensive care facility in Maryland, that they likely would not be issued a CON to do that. But given that this is an acquisition, the commission's authority is quite limited. The Department of Aging has an ability, a limited ability to weigh in on this issue. I don't know what their conclusions would be, but we did share the information that we assembled regarding the parties that are going to acquire North Oaks. And that's all I can report at this point. We are continuing to monitor the acquisition, but as far as the Healthcare Commission is concerned, our authority is limited and limited to the nursing home function at this CCRC.
Thank you.
Are there any other questions for Ben? Okay. Does the executive director have any updates?
Thank you, Dr. Pollack. So I wanted to spend just a few minutes highlighting activities that we've accomplished that really tie directly into our 5 strategic priorities. I'm not going to run through them all, but I do plan to send you a document shortly after this meeting that outlines accomplishments over the last 6 months from June 2021 through the end of this year. And recall that our 5 strategic priorities are: first, to educate and inform and engage the healthcare community on our activities, and to elevate, to use that engagement to elevate the success of the Healthcare Commission's work. Areas that I wanted to highlight here include: we're building and releasing additional all-payer claim database information, sharing it with partners such as the Prescription Drug Affordability Board, HSCRC, the federal agency for health research and quality in the Department of Health at the federal level. We're sharing it with CRISP. We're collaborating on health disparities, both in terms of assessing what the Department of Health is doing to reduce health disparities, as well as working proactively with the new commission, the Shirley Nathan Pulliam Health Equity Commission, in assembling data. And then we are also working with private partners to elevate certain functions of the Healthcare Commission, particularly as it relates to health information technology, where we are now working with Civitas Data Systems, which is a organization of health information exchanges and information regional network collaboratives in some engagements to look at the future of HIEs. Post-pandemic, our teams have been convening nationwide groups of about 60 networks and state agencies to discuss the future of HIEs as we move into the future. We've established an agreement with Civitas Data Systems to host a set of symposiums beginning in late January to look at the future of HIEs. We've also worked with the industry here in Maryland on cybersecurity. In November, we held our cybersecurity symposium in collaboration with HSCRC and the Maryland Hospital Association, and we'll hold another one in January with ambulatory practices in collaboration with Medicaid. In terms of making the MHCC a trusted source of quality and cost information, I'll point out that we've updated the Where the Cost website. We've added 3 new episodes, and we're working to align our episode development activities with the work of HSCRC and the department on the new episode-based model equip, so that we can share information, look at whether payment reform initiatives that are embedded in QUIP translate into information that is usable to consumers. And then, of course, a point that's been made pretty regularly over the last couple months is that we are now well on our way with the approval of the Board of Public Works to begin our work with OnPoint Data Systems, the new APCD contractor that we are really excited about. They announced yesterday that they've also been awarded the APCD contract in the state of California. So that brings to 9, I believe, states that OnPoint currently works with. In terms of data sharing right along with the APCD, making that information available to a broader swath of stakeholders. Our regulations, COMAR 1025-05, have been approved, and we look forward to executing on those regulations to make information available. On the quality report front, there have been new linkages noted in our updates, establishing with this the social neighborhood communication website next door, established linkages, but more importantly, on the website itself, there have been updates to the assisted living facility site. We've added information on assisted living facilities below 10, which has been a complaint on the part of some that information is not available at all. What's available now is limited, but an important first step as we move forward. We have also made substantive updates to make MHCC more trusted source of quality information by updating the measures for hospitals, home health agencies, hospices, and nursing homes. All of that was done in September. So we're moving forward in trying to build trust in our information. It's not a simple site, not a simple endeavor. We've, over the last 6 months, also met with colleagues at the Centers for Medicare and Medicaid Services to talk about what they're doing. And they report some of the same challenges. Certainly one of the important efforts is to become much more publicly visible, and Teresa and her team are working with Maryland Public Television to develop some public service announcements about our website. We expect to go public with a 30-minute public service announcement in the first quarter. In terms of modernizing health planning, progress is made in a couple of the state health plan chapters, but I'm most excited about some work that we started out in June about talking about potentials within the framework, what I call stretching CON, by allowing certain joint ventures between health systems and hospices. We've worked aggressively with our partners at HSCRC to investigate the ability of health systems and others to offer hospital at home, and we've worked, I might say feverishly to issue determinations on ambulatory surgery centers. There's been a raft of acquisitions in this domain as some major health systems, most recent being Tenet, is acquiring significant numbers of ASCs in the state, and we have a role to play in making a determination that CONs are not required for these. But we are seeing some consolidation in that industry, and we're trying to make certain that our health planning capabilities, responsibilities are used and aligned with the evolution of the industry. And lastly, we have done three major things with regard to enable providers to participate in value-based payment models, principally through collaborative efforts. I'll point out, first off, the fact that 2 weeks ago, this Department of Health submitted the MDPCP, the Maryland Primary Care Program Track 3 term sheet to the Centers for Medicare and Medicaid Innovation. That would establish a third track for the unique Maryland primary care model that's been in place for several years. CareFirst joined this model last year. By going to Track 3, we hope to move primary care practices further along the continuum of value. It now is in the hands of CMMI as to how quickly they will approve steps in this domain. We're also reaching out to practices, and we've initiated a new symposium called Innovations in Care. We held our first symposium in September. Dr. Michael Barr, Senior Vice President at NCQA, and Dr. Michael Albert, Chief of Primary Care Clinical Innovations and Chief of Internal Medicine at Johns Hopkins Medicine, presented to about 120 individuals on innovations, particularly as it relates to aligning quality reporting, linking care management to care delivery in primary care. And we'll be launching another one tomorrow on our second in series. And if you are interested in participating, joining that, please let Melanie Cavalier on staff know that. We also are on the verge of getting to the second stage in our Advancing Practice Transformation Initiative grant. That's a $500,000 million grant that we've awarded to MedCai to transform principally primary care practices, but not exclusively so, to make them more able to enter into advanced value-based models. They will, with MHCC's participation, be selecting practices that can participate in this transformation effort. It's modeled after work that was done by CMMI several years ago that MHCC participated in, called the Practice Transformation Network. This is a MHCC initiative on its own based on that experience. And lastly, the fifth strategic priority is to elevate telehealth. I probably don't need to say too much about that. I think we've made significant headways, but not only are we working to promote it, but we are now playing a major role in the state, a trusted role from the perspective of the legislature in assessing whether it's delivering the good value that all stakeholders in the system want. I'll make this available to you, and what I intend to do, because one thing that it doesn't often get translated in public meetings, that the commission and commission staff are operating on these 5 strategic priorities on an ongoing basis. There are also some less than complete successes that we've made, and happy to share those to you as they occur. So stop here and look forward to sending you a short document that follows up on that.
Thank you, Ben. I believe Eileen Fleck will now provide an update on hospitals that the commission is required to provide additional information on as a condition of their certificate of ongoing performance.
Thank you. Yes, there are actually 7 hospitals where a condition was placed related to interventional case review. There's a little bit of variation in those conditions, but essentially all of them are expected to provide documentation that the interventional case review meetings are occurring every other month and that nurses and technicians who care for primary PCI patients are attending those meetings. There were 4 hospitals where the condition was written so that it's just a one-time submission. So if they've submitted the information, they're done. The first of those is the University of Maryland Medical Center, which submitted the information and is in compliance. The next one is the University of Maryland St. Joseph Medical Center, which also has submitted the information as required and is complying. And then also Sinai Hospital has submitted the information. They're doing what they're supposed to and has complied. And then there's Tidal Health Peninsula Regional, which hasn't gotten the information to me yet. And so I'm expecting it later today. But they also do have just a one-time requirement to show that these meetings are occurring with the people attending who are supposed to. And then we have 3 other hospitals where they'll submit the information more than once, and then the commission does need to release them from the requirement. So one of those is Meritus Medical Center. It's submitted the information and is complying. Also, UPMC Western Maryland has submitted its information and is in compliance. And then also the University of Maryland Capital Region Health Center, which is also in compliance. There are 2 of those hospitals that had another condition related to the multiple care area group. And so in that situation, the meetings are supposed to occur monthly, and the hospital needs to submit attendance lists and show again that the meetings are happening and that the right people are attending. So the 2 hospitals with that requirement, both of them submitted the information, are in compliance, were the University of Maryland Capital Region Health Center and then UPMC Western Maryland. For one hospital, there was a 3rd condition, and that was with the University of Maryland Capital Region Health Center, and that related to continuing education activities. The hospital just needed to provide documentation that those activities were happening, let us know what those activities were, and who'd participated in them. And so the hospital is complying with that.
Thank you. Any questions for Eileen? Thank you, Eileen.
Thanks.
Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform the chair. For commissioners participating remotely who desire to recuse, they should remain silent, turn off their cameras, and mute their phones. I do not believe we have any commissioners who are on site at this point.
Mr. Chairman, Andy,
Commissioner Jordan.
I had a question about current events related to COVID that I would like to just ask. And before we get on, would that be under the executive or should I wait till later?
I think now is probably as good a time as any for that, actually.
Okay, I will hold you up, but I always enjoy your thoughts on where the world is related to COVID, and clearly a lot has happened in that arena. I read the other day, and this specifically probably would be to Ben, about the governor who was pledging to do all these additional things for hospitals. And I didn't hear him say anything about doing anything for nursing homes, which is another subject, I guess. But I never heard what he was going to do. Was it more money or whatever? And the real issue, does it have any impact on our commission?
Ben, do you want to take a spot? I'm not sure how to answer with regard to nursing homes.
Yeah, I mean, I think, let me So
Well, even hospitals, I don't know what the governor has done more for. It sounded like he was gonna help hospitals or whatever. Again, he didn't mention nursing homes or other type of facilities. I was just curious if there was any clarification you might know.
So I'll have to get back to you to confirm that I have all of the information. What I am aware of is he has relaxed some of the requirements on use of out-of-state providers or individuals with out-of-state licenses. But I don't want to, I need to clarify what that actually means in terms of actual funding that would tie back to any of our activities. I don't believe there's anything specifically that will require us to do to anything. Keep in mind that we have about 40 emergency CONs that are still in place. That doesn't account for the tents that were established at many of the hospitals. We issued a guidance to the hospitals that they could continue their emergency CONs up through April 30th of 2022. We thought that was ample time to provide for continuation. After that date, they would either those ECONs would end or they could apply to make those permanent. We are aware in several cases of hospitals that plan to apply to make those permanent. What is the outstanding question today is with Omicron yet to hit and Delta still growing in strength, whether April 30th is too soon for ending those emergency CONs. We'll look to the secretary as to whether he wants to request the Healthcare Commission extend those emergency CONs. With regard to the nursing home community, I think there's some of those same relaxations would apply to staffing issues at nursing homes. But keep in mind that last year there was a Medicare fee increase for nursing homes. I don't want to cite the percentage increase. Maybe Commissioner Metz could comment on some of that. He may be more familiar with it than I am off the top of my head. But there were some reimbursement increases under Medicaid, which were certainly sought after. I should note that many of the nursing homes are facing significantly greater challenges, and thus the spate of acquisitions. Occupancies are down in many facilities around the state, but not all. Commissioner Metz, do you have anything to add?
Yeah, a couple things. I addressed a little bit of both of that. We're kept in pretty good contact with the state regarding both the hospital situation and the long-term care situation. There was some specific, most of the recent actions were directed at hospitals. Couple just summary that they wanted some closer coordination with the Maryland Department of Health with hospitals, surge operations center management, different thresholds. They established different thresholds for hospitals to take actions. They had to submit pandemic plans. I would have thought maybe that was already completed. Expedite healthcare staffing needs. Some of that what Ben spoke to with retirees, et cetera, being able to re-enter the workforce much easier without recertifications and some things along those lines. New initiatives to encourage boosters and vaccinations across the board. So there's some, there's limits on elective surgeries again and different things such as that on the hospital side. The long-term care side, there wasn't really any new directives. Ben's right, there's been some relaxations on like visits and et cetera. Staffing continues to be a challenge across the entire industry for long-term care and hospital. I know they're talking about some grandfathering actions with some of the temporary type GNAs or CNAs, looking at new initiatives to get more people licensed in a more expeditious fashion instead of, the traditional routes. But that's kind of what's going on. The larger worry, and then you see the CDC kicking out some, and they're typically pretty reserved, but taking some pretty profound statements out there on what they call like almost a three-prong worry with Omicron, Delta, and the flu all at one time. So they're anticipating some real challenges for hospitals in January. So that's what's driving all this.
I agree with all that. I think the only thing I'd add to that, Chip, is that this staffing challenge at this point can't be underestimated. In 27 years in this business, I haven't seen a staffing situation like this or
Good.
even close. I'm not sure the retiree population is there to fill it. I'm not sure that there's any population there to fill it. I don't know what we can potentially do. I know that we can potentially compete nationally better than we have for the travelers that are out there. We've sort of avoided that market by setting caps in the state with regard to how much, no official caps, but by limiting how much we'll actually pay. I think the without question, the GBR system has protected us, the hospitals, very well through the first surge. But what it's also done is it really, by protecting the revenue stream, it limits the willingness to go above threshold levels with regard to how much you'll pay for travelers, because you know that the revenue stream is protected. I give an example. We had a speaker here from Stanford last month, and they are paying substantially more for travelers than we're paying right now. And there is a Bay Area premium, certainly, but it's not as big as the one that we heard. What's different is that without the nurses in place, the revenue stream suffers at those institutions, and it doesn't suffer here. That said, we're holding true with keeping most of our available beds open, but as people know, we operate these hospitals on a day-to-day basis with very slim margins with regard to the number of staff beds versus the number of needed beds. So there's very little additional margin that is available in the event of turning back. And we're turning back a little bit in terms of the number of beds we can offer, and we're seeing an increase in the number of people who need the beds. And the turn back in the beds we can offer is because we don't have staff, and any emergency plan doesn't work if you can't get more staff. So
Right.
that's where we sit. Jeff talked about the challenge of the 1,200 and 1,500 numbers that the governor said when the levels get to 1,200, there's a certain set of guidelines with regard to cutting back on elective surgery, and at 1,500 there are other guidelines, but those are soft. They really are. There's not a clear definition anywhere of urgent versus emergent versus elective surgery. Very few people who have surgery really describe what they're having as purely elective. That which is almost always done in a surgery center anyway. So
Thank you. Much appreciated.
can I ask folks carefully to check your microphones and make sure they're muted if you're not speaking, please. Thank you. On to agenda action item number 3, our first action item. The Maryland General Assembly passed legislation effective 2003 requiring the Commission and the Health Services Cost Review Commission to report annually on the status of the Maryland Trauma Physician Services Fund to the General Assembly. In accordance with Section 2-1257 of the state government article, the report and presentation slides were included in your agenda packet. Richard Proctor, our Chief Operating Officer, will present the highlights of the report and answer any questions in advance of the Commission's vote to approve submission of the report to the General Assembly. For Commissioners, remember, we're just being asked to approve submission of this report to the General Assembly at this point.
Thank you, Mr. Chairman, and good afternoon for Commission members. It's my pleasure to present the report, the 2021 Maryland Trauma Physician Services Fund report to you today. But first, I'd like to acknowledge Denise Ridgely of our staff for her ongoing management of the fund and her role with the initial drafting of the report and her involvement and guidance throughout and through it until its completion. And also Ben Steffen for his ongoing insight and guidance and leadership as it relates to the fund. Much appreciated. I have a series of slides which we'll go over briefly. You received the report as the chairman indicated. I just want to make note of a couple items from the executive summary portion of the report that feeds into the rest of this of my presentation. The COVID-19 pandemic was still a significant part of fiscal 21. The vehicle registration renewals were still covered as part of the Governor's Hogan's state of emergency, allowing residents to delay renewing if they so chose to do so. However, there was an increase in vehicle registration renewals as restrictions began to ease in the early part of 2021 for Maryland residents. And with these easing of restrictions, folks were able to travel more for work and pleasure. And there was an increased cost associated with uncompensated care and Medicaid supplemental payments based on that. Also, the commission continued its policy of paying uncompensated care and on-call stipends at the 105% Medicare rate that was established in 2017. First slide, please. This is just the background. Again, this is in your packet in the report. It's page 1 of the report. I just want to note the foundational statement that the General Assembly established the fund in 2003 to aid the trauma system by reimbursing trauma physicians for uncompensated care and raising the Medicaid payments. Also established a formula for reimbursing trauma centers for trauma-related on-call expenses. Really want to note on this slide that the legislation directed HSCRC to allow trauma centers to include trauma-related standby expenses in approved rates. And also the statute's been modified various times, and previous to my term with the commission, I know the commission was briefed on the various times that the statute was amended. Be happy to do that again if there's interest. The most significant statutory change have expanded the eligibility for the fund payment levels for classes of providers. The last legislative action was in 2019, where the legislature included PARC for standby, eligible for standby payments. Next slide, please. The collections for the $5 motor vehicle surcharge total 12.5 million compared to 11.8 in 2020. Again, 2020 was when the executive orders took hold. The fund dispersed about 11.4 million to trauma centers and trauma physicians, 1 million to PARC. And of note is that the HCRC did incorporate PARC's allowable costs in their hospital rates effective January 1st, so that was significant. Uncompensated care costs total about 2.1 million compared to about 1.1 million in the previous year. And payment for on-call services totaled 8.4 compared to 8.3 the previous year. On this one, I wanted to note that on-call costs have increased each year over the last several years and continue to do so year over year. The fund balance represents now about 66% of our total cost. The fund balance was $2,171,071 compared to $2,085,101 in the previous year. Next slide, please. This is an elaboration of the previous slide. I just wanted to restate that the COVID-19 pandemic did have an impact on the revenue both in 20 and 21. The executive orders were in place during that period of time. Uncompensated care costs have already stated. The Medicaid payments totaled 0.3 million compared to 0.2 million in FY20. The payment for on-call, again, restated, needs to be restated, I believe, because this is our biggest driver of costs. And almost all the trauma hospitals are now collecting the maximum on-call allowed by law, et cetera. So this is something we have that's in later slides I want to make note of. So next slide, please. Outstanding obligations. This is just when we reimbursed 4.9 million in obligations. This is or obligations are on-call or standby stipends paid by the hospitals January to June of the year, but not reported to the commission until the end of after the end of the fiscal year. As in the past years, these obligations are paid from the fund in the subsequent year. Those funds have been paid this year. Next slide. Expectations for 2022 and beyond, boil it down to three, I believe, rather straightforward expectations. On-call payments representing about 2/3 of the total spending I referenced earlier will continue to increase. Trauma centers will continue to inquire about increasing the $5 surcharge on motor vehicle registrations and renewals. And level 2 and 3 trauma centers will continue to inquire about larger trauma equipment grants. Just want to note here that our balance last year ended at about over $2 million. So this year, the grants total is about $200,000. That process is underway. We have received the applications. They are pending approval at this time. Next slide, please. This is options for modifying the trauma fund and revenues. This would require statutory changes, and it is table 8 in your booklet, in your report. Increased motor vehicle surcharge on registration and renewals from $5 to $6. We estimate that would raise approximately from $12 million to about $14 million if that was done. Reimburse on call at 105% of authorized levels net of obligations for uncompensated care and Medicaid supplemental payments. By the way, that table 8, there's a discussion note in each of these. So if you haven't seen it yet, you might want to look that over. And if you have any questions, feel free to ask. Contingent on revenue increases, one, increase the level of trauma equipment funding to $1 million per year for eligible trauma centers. As again, right now, as you know, by law, it's capped at 10% of the previous fiscal year. This would allow more funds for those badly needed equipment. And if we did that, it would be up to about $140,000 per trauma center. Authorized uncompensated care and Medicaid supplemental payments for non-physician practitioners providing trauma care. These professionals work side by side with the physicians during this, of course, and certainly there's a thought that they should be are also worthy of being reimbursed. Direct the commission to conduct annual review of uncompensated care and Medicaid supplemental payments to confirm that the MCOs are reimbursing at the mandated level. There has been some concern in the past that that's not the case, and we've had to take action in the past in regards to that. So it's something that we've cited for your consideration going forward. And set the statutory floor and practitioner fee levels for uncompensated care and Medicaid supplemental payments at 105% of the Medicare rates. Currently, the rates when they first were established does not take into account the fact that these complex and medically complex cases are handled by the trauma professionals throughout the day. They don't handle sometime during the day and others not, and other cases during the day. This is a total dedication to the complex cases, and they should be considered as that consideration should be given to them to set that statutory floor higher. So also the next slide, please, is in the report. It's table 2, it's page 4 of the report. This just shows you the cash flow from 2019 to 2021. We've already restated it. You'll notice that in 2019, we had 11 million, but then we had the Budget Reconciliation Act that year, which reduced it balanced to 3,906,000. But you can see the difference between 20 and 21, where we are now, where we stand with each of the items on the fund. The next slide is table 7, page 12 of the report, and that's the actual and projected trauma fund spending from 20 through 22. And you can see here in FY '20, as I noted earlier, and then '21, and now the projection for '22. So just a note, the end year balance for '20 was a little over 2 million and a little bit 2.1 million in '21. And we projected that we will end the fund with a balance of about 2.9 million in FY '22. That concludes my brief overview. If there's any questions, be happy to address them. Otherwise, that's concludes my review. Thank you.
Are there any questions for Richard about this report? Thank you, Richard. That's a great summary and more to consider in the future here.
Thank you very much.
Do I have a motion to approve the trauma fund report to submit to the General Assembly?
So move, Commissioner Jordan.
So moved.
Second,
Second, Commissioner Boyle. Any additional discussion?
I have a question.
Commissioner Boyer.
Are they asking us to make recommendations to increase the revenue for the fund?
My understanding is no, that right now we're submitting the annual report, and that report includes some potential suggestions at the back end.
That's correct,
So
sir.
therefore, we as a commission are suggesting that the Maryland General Assembly increase the registration fees by $1.
If I could, these are options. There have been discussions within the trauma community of raising the fee from $5 to $6. There's no action pending or contemplated, certainly not by the commission, to put that forward this session at all. But there has been discussions in the trauma community about that. We just wanted to note that there has been discussion about that potentially, whether this year or sometime into the future. But we have not, I'm not aware of any legislation that's being introduced this session.
Should it be annotated as such that there's discussion within the trauma community to increase it versus a recommendation or an option being put forth by the Maryland Healthcare Commission, increasing it by $1?
It's in the report.
It's an option. It's not a recommendation or a request to put forward.
Slide deck is ours. The report is what goes to the General Assembly.
If it helps, Commissioner Blair, I had the same concern in the last paragraph on page 11, says that MHCC will work with policymakers to examine the funding challenges, and then they list a bunch of options that include modifying reimbursement levels and achieving operational efficiencies, among other things. So I didn't see that myself as necessarily biased towards an increased fee. I think as long as all of the matters are on the table, at least personally, I was okay.
Correct. Thank you, sir.
The slide deck is less clear than the report, is the
Correct. I agree.
Are they going to be provided both?
Pardon?
They get
Will the General Assembly be provided both?
There again, there's no contemplation on the part of the staff of the commission to put forward. We're not putting forward any legislation this year at all, and nothing.
understand.
that wasn't a question. I want to know if they're getting both the slide deck and the report.
Oh,
Just the
they're
report.
getting the report. I mean, the report, not the slide deck.
Okay, thank you.
All right, all in favor of approving the report as written?
Aye.
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 Any opposed or abstained? Very good. Thank you, Richard.
You're welcome.
Agenda item number 4, hospital at home in Maryland. During the 2021 legislative session, the General Assembly adopted a joint chairman's report directing the Health Services Cost Review Commission and the Maryland Healthcare Commission to report on using hospital care at home in Maryland as an optional service. Hospital care at home programs provide hospital-level acute care in a patient's home as a full substitute for acute hospital care. Such programs have been implemented as demonstration projects in the past, and more recently have been authorized by CMS as part of the federal government's response to the COVID-19 pandemic. In October This commission endorsed the view that the certificate of need regulation was not a barrier to implementation of hospital care at home programs in Maryland. The commission has now received the complete draft report to the Joint Chairman for review and approval. HSCRC staff took the lead in developing this draft. Paul Parker, Director of Healthcare Facilities Planning and Development, will brief the commission on this report. Paul, please proceed.
Thank you, Chairman Pollack, members of the commission. This is a mercifully brief report, as you will see. It's only 8 pages long, so I won't spend a lot of time reviewing it. You probably will recall, as Dr. Pollack mentioned, that in October, we asked the commission to endorse one of the key demands by the Joint Chairman, and that we look at what regulatory barriers may exist in Maryland to hospital at home programming. And we determined that certificate of need regulation was not a barrier, and that's reflected in this report. So the bottom line of the report is that the two commissions are through approving this report, endorsing the concept as one that fits well with the objectives of the payment model in Maryland. You will see that HSCRC staff has outlined 2 possible options for creating a specific payment model for this type of program. And I would characterize the preferred option as one which HSCRC believes it is able to implement fully on its own without having to go back to CMS for approval. This would be creating a bundled payment rate for hospitals, which is really under the outpatient heading. This would mean that hospital at home would be paid for through a higher reimbursement rate for an emergency department service that triggers an admission to hospital at home. And other than that, I really don't have anything else that I need to say about this report. We recommend that you give it your approval.
I have a question,
Let's get
Mr. Chair.
why don't we get a motion first to adopt the report, and then we'll discussion.
So moved.
Commissioner Jensen, second. Second.
O'Connor, second.
All right. Discussion. Commissioner Sargent. You're muted.
That's how people like me. First, the last go around, we were talking about barriers to hospitals doing this at home. And I was thinking, well, there aren't barriers to hospitals doing this. But when we're talking about bundled rates and higher levels of payment, we're not really reducing barriers. We're sort of protecting hospital turf, it seems to me. And tell me what's wrong with this, but with my logic here, because it could be wrong. I'll acknowledge that. But it seems to me that hospitals can take services, they can develop in-home programs, they can recognize that those are more efficient, cheaper ways to deliver services. It brings down the healthcare dollars for everyone, and they can reduce their global budgets accordingly. And nobody is stopping them from doing that. So there is no barrier. But what we're talking about now is let's find a way to pay hospitals more than somebody else might do to do these in-home services. And it looks to me like it's protecting turf. And isn't that a little bit like putting Sears in charge of finding a new way to get products to people's houses instead of Amazon? Like I said, that's maybe an inflammatory example, but I'm using it to illustrate a point. Like, should hospitals at home, as we call it, it's a set of bundled services. I'm not seeing what's unique to a hospital, which the whole idea of hospital regulation is predicated around a physical plant with a building and a location and an institution. And why are we importing all that into the home setting and paying more for it to boot?
Well, I'm not sure I understand when you say we're paying more for it, because obviously the idea here is that certain patients, primarily being identified with their presentation in a hospital emergency room, would be identified as appropriate for this alternative mode of hospital care. So rather than being admitted to the hospital, like traditional hospital patients and cared for in the hospital, they're going to leave the hospital emergency room.
I don't see it. It is 2:03 your time. I want to take a minute to say thank you to Jennifer and Lisa for their organization, for getting in touch with the witnesses, for thinking about the different topics, you know.
Thank you.
Okay, so I think, we're basically saying that some, strata of hospital patients who are currently being admitted to the hospital and experiencing an inpatient stay, they would be, put on an alternative track. They'd receive acute hospital care at home. That hospital would be reimbursed on the basis of as an outpatient service, because this would just be an enhanced level of payment associated with the emergency room visit. And the expectation is that this would actually, be a lower reimbursement level for that patient than what would otherwise be experienced.
Paul, is this within the GBR or outside the GBR? If it's a hospital-based outpatient service, it's within the GBR, right?
Yeah, but the GBR is not really going to be affected by this.
So I get that the GBR doesn't change, but
Right.
that's exactly the point. If it's billed within the GBR and it's counted against the total GBR for the hospital, then it's not increasing the total cost of care. If this is getting billed outside of the hospital's GBR, in other words, if this is an unregulated service that the hospital is able to provide, then it adds to the total cost of care, because Commissioner Sargent's right at that point. They keep their GBR and then they can bill outside of it. And it's a protected service that home health care agencies can't, for example, bid to provide at a lower level. So I think that's key, that we're talking about hospital at home would be hospital services provided by the hospital within the hospital's existing GBR.
But this is not home health care. Home health care is rehabilitative services that are needed by a patient after, typically in the world of Medicare, after a hospitalization. This is hospital care at home. And when you say it's not under the GBR, all of the revenue received by the hospital is under the GBR. So even the revenue that a hospital will receive for a hospital at home patient is going to be revenue that's going to have to align with the GBR for that hospital.
Okay, that answers the question. The revenue has to align with the GBR, but understand what you just said is not true. Not all revenue the hospital receives is under the GBR. For example, if the hospital owns an ASC off campus, the revenue that comes through that ASC is not under the GBR. If the hospital owns an outpatient physical therapy practice, that's not under the GBR. If the hospital has physical therapy, outpatient physical therapy inside the hospital, where patients come in, get their therapy, and then go home, that is under the GBR. So that's sort of the fine line here. And the idea that somehow there is a sharp line between what home health delivers and what hospital at home would deliver, that's flawed. Because, if somebody comes into your hospital with cellulitis, for example, and goes and needs a course of IV antibiotics, that could easily be delivered in a hospital at home model. It could also be delivered in a model where you discharge somebody from the emergency room and set up home healthcare services for the home IV antibiotics. So there's a lot of gray area in between the two. And I get Commissioner Sargent's point very clearly.
I think you said it more kindly than I did, Mr. Chair.
What's that?
I think you said it more kindly than I did, because I was trying to get folks to think of the example. But I think that's it. I'm had trouble breaking down what the hospital home services are that require a hospital, because I thought the core of how we'd previously defined hospital services were services in a hospital. So are we expanding what we think of as a hospital? And I guess given all of the regulation about hospitals, I'm not sure I want to expand hospitals themselves out into the world more. Does that make sense?
Yeah, I think, it makes sense. But I think as long as the clarification that we got here, that I think it's important, is that this revenue, if hospitals receive it, would be under their GBR.
Because it will essentially be enhanced emergency room revenue.
Got it.
So, and I'm sorry, I don't want to monopolize the discussion. That leads to my second question, though, was then assume that we have bundled payment and it's enhanced revenue. But we're not talking about stopping other people from picking up those same services and competing with them for a lower price, are we? Because then the next step is, are we going to try and protect those services as hospital services by expanding the regulation? And then that gets right to my point of, is that really the health system of the future, right? Are we taking advantage of all of the opportunities to drive services out of large institutions and into cheaper settings by just expanding the scope of the hospital reach into the home?
I think in order to answer that, we need to have a full understanding of the total scope of what's possible under hospital and home services and decide how much of it is gray between what could be home health care versus hospital at home. How much of it is where there's a crystal clear differentiation, and the hospital at home is something dramatically different than home health services. I've sat through a couple presentations on this thing thus far, and I've yet to get a clear answer to that. In other words, to give a real coherent example of a case where this is clearly a hospital patient being taken care of in the home setting, versus one of those gray area cases.
Thanks. Does anybody else have any? I had another question, but I will wait. Let me see if anybody else wants to
go. Please go.
Okay. And I guess the question that I have then is wanting to make sure that we are, if hospitals are extending the services and they're not clearly hospital services, but now they go under the cap or they're bundled, then we are sort of losing the opportunity to say no, go to a lower cost setting and reduce the budgets. And I think that's sort of we said at the beginning, but I think that sums up my concern.
So just to clarify, Paul, this report is not making a recommendation one way or another to anybody.
It is, I think, making a recommendation to the joint chairman. So it's making a recommendation to the legislature that that hospital at home programming can be implemented in Maryland. It puts forth a way in which HSCRC would do that.
But it doesn't make a recommendation that it should be implemented at this point.
It supports the idea that it is consistent with Maryland's objectives. So I would say it is a supportive report for the concept.
Does it leave open, though? There's one issue is the concept of hospital at home. The related but separate issue is how is care going to be what's the cost going to be for the hospital at home, right? So doesn't it separate those two out? It says, hey, we could do hospitals at home and leave open the issue of exactly how would HSCRC deal with the pricing of that.
Yeah, actually implementing this hospital at home, or the opportunity for hospital at home programs to be developed, would clearly require further action by HSCRC to approve the specific payment model that they're going to use.
Other questions or comments? When is this due?
I believe by January 1st.
I was going to say, like, my concern is not so much with this is how you would bill it if you're a hospital. It's that it starts to slide towards necessarily then the at-home service from the emergency room is going to be provided by the same institution. And we're foregoing somebody that can really do it. I think doing at-home service as well is going to require the focus that one has as an Amazon of how do you deliver things in the home really well, right? That anybody who already has a dog in the fight lacks that focus because they have interests to protect. And I'm concerned if nothing in this document recognizes there may be other providers or better ways of doing it, and that it's just sort of assumes that we want hospitals to take this burden on. And maybe there's some qualifying language that could be added that would say, no, we don't mean to get into that fight.
So I'm not sure. I really hadn't thought about your comments when I read this report the first time, and when I look back now and read the conclusion, I'm uncomfortable with the strength of the conclusion. Do you want to propose some additional language to the or some modified language to the conclusion that we could take as an amendment to the motion?
Let me think on that. I mean, is it something along the lines of nothing in this report is intended to take an opinion on whether hospitals would be the best or most efficient provider of in-home services?
Paul, what do you think about just deleting the last sentence?
Doesn't the last sentence say, though, for that reason, the commission supports the uptake of the model by hospitals and other entities across the state? I mean, the other entities, I mean, perhaps you could make that more clear, but doesn't that address Commissioner Sargent's issue?
What if we were to just delete by hospitals and other entities and just say the uptake of the model across the state?
Yeah, but
It'd be the same thing.
But I think the phrase "other entities" is the only thing in that conclusion that specifically expands it beyond hospitals.
So I think Commissioner Jensen's point is that the current language really does protect Commissioner Sargent's concerns and gives us flexibility when we testify on this issue to stay within the lanes of the report and suggest that whatever language is adopted shouldn't monopolize a position for hospitals.
And I would even go a step further and say, if we wanted to expand on that other entities in a way that would further underscore Commissioner Sargent's point, perhaps we could do that. I'm just not quite agile enough to think of that language and talk at the same time.
That easily, we could just give an example. We could say such as home health care entities.
Yeah.
Yeah, I mean, we could say entities, provider entities. It's not really a huge change, but because of course
we could change other entities to other provider groups,
including entities currently not licensed as acute general hospitals in Maryland.
You know, that would help me, right? There's recognition that these are not necessarily hospital licensed services, and then
There you go.
people can compete.
I like that. So Commissioner Sargent, you want to propose that as a friendly amendment?
Sure. Ben had the best wording, but we're going to change where it says and other entities. Ben, could you just re-say what you said? It was
other entities currently not licensed as acute general hospitals.
Okay, it was this. It was other provider entities, including entities not licensed as acute care hospitals. How's that?
Not currently licensed.
Not currently.
Not currently licensed. Okay.
As acute general hospitals.
Okay.
So
Do I have a second? Ben, go ahead, sir.
So just commissioners be aware that we will have to take this back to the HSCRC because it's a joint report. So we may need to briefly convene. Hopefully they would see the logic of this change. I don't think they would object.
Yeah, I don't think they would.
I can't speak for them.
Right. Okay. Do I have a second to Commissioner Sargent's proposed amendment?
Second.
Second, Commissioner Boyer. Okay. Additional comments or questions? Great. Hearing none. All in favor of the report with the proposed amendment?
Aye.
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 Any opposed? Excellent. All right,
Thank you.
agenda item number 5. I think. Yes. The Maryland General Assembly passed legislation in 2021 that requires nursing homes to submit electronic clinical information to the state designated health information exchange, CRISP. The law also mandates that electronic health networks certified by MHCC submit administrative healthcare transactions to CRISP. The MHCC is tasked with updating the Governor and General Assembly on the availability of funding and technical infrastructure sustainability by January 1, 2022. Nikki Majewski, Division Chief in the Health Information Technology Division, will present on the legislative updated briefing paper. Nikki, the floor, so to speak, is yours.
Thank you. Good afternoon, commissioners. Healthcare data, next slide, please. Healthcare data is sourced from a variety of systems, and combining data from multiple sources is key to unlocking its value and potential to improve the healthcare delivery system. House Bill 1022 represents a significant step towards linking different data sources and improving data analytics to achieve better quality and health outcomes. The legislation authorizes CRISP to make information reported by nursing homes and electronic health networks available to authorized healthcare providers, HIE users, and state and federal officials to facilitate a state health improvement plan, mitigate a public health emergency, and improve patient safety. Electronic health networks, or EHNs, are the healthcare clearinghouses, which I'll elaborate more in a few more slides. Next slide, please. The law requires the Maryland Department of Health to identify the appropriate funding to support implementation, and MHCC is tasked with reporting on funding and sustainability. This briefing is to provide you with this information, and that update, as Dr. Pollack mentioned, is due to the General Assembly and Governor by January 1st. Next slide. There is greater need for robust healthcare data analytics, especially to support the shift to value-based care. Data collected across multiple sources for purposes of public health surveillance provides more information that can inform care delivery. It can also provide better estimate of the magnitude of problems, identify groups higher risk of having poorer outcomes, examine relationships between risk factors and outcomes, develop interventions, and then improve monitoring of those interventions over time. Improving healthcare surveillance depends on effectively combining data into actionable information. The work CRISP has done in this area will better inform decision-making at the point of care. Data-driven approaches using information from health IT systems is essential to ensure providers have critical information to help patients achieve their full health potential and improve population health in the state. Next slide, please. A leading value add for nursing homes is access to information that can improve quality of care and care coordination when older adults transfer between nursing homes and hospitals. It's important to note that nearly all nursing homes in the state have adopted an EHR, and the 2 EHR systems used most by about 90% of nursing homes include point-click care, which is the largest share at 77%, and then matrix care at 13%. Next slide, please. EHNs, or the healthcare clearinghouses I mentioned, are the middleman between providers and payers, essentially the senders and receivers of large mountains of electronic information, which had more than a decade ago been carried out on paper. Today, healthcare clearinghouses process billions of administrative healthcare transactions each year. EHNs are required to comply with HIPAA, and under HIPAA, the U.S. Department of Health and Human Services adopted national standards for administrative healthcare transactions that specify the format for the transactions and requirements to safeguard the electronic exchange of the information. Combining administrative healthcare transactions with clinical information will lead to use cases that bolster public health initiatives. And it's important to note that existing regulations require payers operating in the state to only accept administrative healthcare transactions from MHCC certified EHNs. Certification requires EHNs to be accredited or certified by a nationally recognized organization. And this ensures EHNs meet standards related to privacy and confidentiality, business practices, physical and human resources, technical performance, and security. There are approximately 30 MHCC certified EHNs operating in Maryland. Next slide, please. It's worth noting too that in 2015, MHCC funded a successful demonstration between CRISP and 2 EHNs. The demonstration tested the feasibility of integrating administrative healthcare transactions into the HIE, and it was determined that the transactions could be used to supplement clinical information at the point of care. The pilot included 32 practices, 68 providers, and around 16,000 claims transactions. Some challenges were identified, such as scaling to meet high volumes of administrative healthcare transactions and data timeliness. In September of 2021, MHCC convened several EHNs to begin exploring technical and policy matters to be considered when implementing the law. It was concluded that broader EHN participation was needed, and MHCC then engaged the Cooperative Exchange, the National Clearinghouse Association, to do a deeper dive into the challenges and ensure policies are thoughtfully crafted to meet the aims in law. Staff met with representatives from the Cooperative Exchange earlier this week to discuss key considerations to making administrative healthcare transactions available to CRISP. And we plan to convene a stakeholder work group in January to work through potential challenges and identify solutions. Next slide, please. So staff in collaboration with CRISP have concluded that the existing HIE technical infrastructure can support the requirements of law. The estimated cost to connect point-click care and matrix care with CRISP is about $330,000 annually. Those are those 2 EHR vendors used by most nursing homes in the state. Funding would support use case development, compensation to the EHR technology channel partners, data quality audits, and data storage and security. The cost to integrate the administrative healthcare transactions is about $180,000 annually. Actual costs would be lower or higher depending on the volume of transactions and number of use cases. The EHN industry sees value in sharing this information for public health purposes, but identifying a long-term funding source is critical. Next slide, please. So finally, in 2022, CRISP is planning to integrate with point-click care and matrix care. In addition, CRISP expects to begin accepting administrative healthcare transactions from EHNs that process nearly 99% of all transactions statewide. And staff has begun working with stakeholders to identify clinically relevant use cases where administrative healthcare transactions combined with the clinical data can improve care delivery. Next slide, please. So that concludes my presentation.
Questions for Nikki?
Andy, Chip,
Commissioner Gordon?
Nikki, I only know enough about this to be dangerous, and I may be talking apples and oranges, but I know the governor came out this year and put a mandate on nursing homes for daily reporting, which ended up actually with some significant penalties if you weren't totally in compliance. Is this part of that whole system of what we have here? And I guess I assume this doesn't relate to hospital systems at all, and it's just with nursing homes. But is there anything hidden here, or that we may be authorizing or doing something that could have a significant impact on any industry, but specific the nursing home industry in a negative way?
So given this, we'll identify a funding source to help supplement some of that integration with their EHR vendors. I think this will help because that existing reporting requirement does exist, but it will expand the scope of what is to be reported. But I don't believe there are any necessarily fines tagged on to that at this juncture. I know we would have to develop some regulations and coordinate with the department to flesh out the details of the reporting structure for this particular purpose.
Dr. Pollack.
Yes, Commissioner Metz.
Yeah, this way I see this is, and Nikki can correct me if I'm wrong, this is more piggybacked off of previous attempts to connect electronic health systems across the state to CRISP. I was involved in a pilot some number of years ago. It's good that this study and involved both point-click care and matrix care. They're at that level where it could be integrated and implemented through those systems without too much difficulty. One of the challenges we had in the past was all the different individual systems being able to be linked to together. Chip's right about some of the reporting requirements. I don't think that this is linked to that. We're hopeful that some of those reporting requirements can be consolidated into maybe once a week. They're pretty tough. You can report some hundreds, 300-400 times in a row, miss one day and get fined $2,500 on information that largely doesn't change from day to day. So hopefully that sheds a little light on some of this.
This is David Sharp. Dr. Pollack, may I weigh in here, or would you prefer me to just remain in the wings?
No, please weigh in, David.
Thank you. Good afternoon, commissioners. I think Nikki did a really good job of sort of teeing this up, but let me try to talk a little bit more about Commissioner Dordan's question. So, and combine it with Commissioner Metz's point. This is actually a good thing for nursing homes because historically they've operated in digital silos, and much of their information can be used for public health purposes. And what this enables is for the Maryland Department of Health, upon request of nursing homes, to ask for more information that can be used to augment certain public health initiatives, as well as inform clinical care. So to Commissioner Metz's point, when a patient transitions from a nursing home to a hospital in the acute care setting, historically there was no information that flowed with them, or it was a paper record that was attached to the stretcher, or hand delivered by the ambulance, the transporting crew. So this would enable the integration of these solutions, these electronic health records, to be integrated with CRISP, which would mean at the point of care delivery, the hospital in this scenario would have access to the complete medical record, or what exists, the medical record at the nursing home of origin. So it has many values, but there aren't any hidden disincentives for nursing homes with this approach. The only disincentive would be, if there is one, is that we have funding to integrate, but we don't know what the long-term sustainability of that funding looks like. So year one, we're set. Year two, we might not be. Year three, it could be. So some of the outlying years we'll have to keep an eye on. So hopefully this helps, Dr. Pollack.
Thank you, David. I think that was a very useful description. Other comments or questions from commissioners? Nikki, thank you. David, thank you. Agenda item number 6 will be an update on collaboration with the Office of Minority Health and Health Disparities. During 2021 legislative session, the General Assembly renewed a focus on the collection of race and ethnicity data to support the state's ability to address health disparities. HB 309, SB 565 requires the commission to work in coordination with the Office of Minority Health and Health Disparities and the department to develop a report to the General Assembly by December 31 on the Maryland Department of Health's current goals and implementations to eliminate minority health disparities. As a first step to respond to the new legislation, the commission and OMHHD staff collaborated to develop and administer a questionnaire to obtain descriptive information on all MDH programs that directly or indirectly address the needs of Maryland's vulnerable populations. Diana Estefania Estrada Alamo, Program Manager, will provide an update on this staff activity.
Hello, can everyone hear me?
Yep, loud and clear, Diana.
Great, thank you, Mr. Chairman. Good afternoon, Commissioners. My name is Diana Estefania Estrada Alamo. I am a Program Manager within the Center for Quality Measurement and Reporting. My focus is health disparities initiatives, and I will be presenting to you all today a high-level summary of the MHCC's collaborative project with the Office of Minority Health and Health Disparities in fulfillment of House Bill 309, Senate Bill 565 on public health data that was passed during the 2021 legislative session. Next slide, please. House Bill 309, Senate Bill 565 requires that the MHCC and the Office of Minority Health and Health Disparities work together to achieve several asks under the umbrella of implementing a plan to eliminate minority health disparities in Maryland. Our teams have been working together diligently for the past 6 months to develop an exploratory report that could serve as the initial foundation for such a plan, and that will be submitted to the General Assembly December 2021. While we understand that our report is limited, as the centralization and aggregation of existing MDH programs and implementations that serve vulnerable populations has not existed previously, we do believe that the findings and recommendations of our report are valuable towards the goal of the bill. Next slide, please. In order to amass existing MDH programs related to minority health disparities, the MHCC and the Office of Minority Health and Health Disparities developed and field tested a vulnerable populations questionnaire. The final product had a total of 25 questions that ranged in topic from funding sources, data variables collected, metrics used to measure performance, goals and objectives of the program, and more. We provided this questionnaire over a virtual platform as well as a fillable document that organizational units could share and use collaboratively. Questionnaire administration was very labor intensive for several reasons. Firstly, communication with organizational units was more complex than we had anticipated. We needed to determine points of contact for each program, and that information was only readily available for some units. Moreover, the elaborate structure of MDH made it difficult to keep up with leadership changes and distinctive aspects of management and classification within each unit. We received assistance from MDH and MHCC leadership to escalate requests for submission, but even then, some organizational units remained unreachable. Secondly, the virtual platform used provided its own challenges in terms of data extraction and deduplication. As such, staff had to perform more tasks manually than would have been ideal in order to remain flexible to submission deadline extensions, resubmissions, large attachments, etc. By the end of October, we received a total of 405 programs, reported over 150 unique respondents. Submissions were a mix of programs that operated at the state level and those that operated at the county level. We chose to organize our findings predominantly by SIHIS objectives and by jurisdiction served. To do so, we stratified data by condition focus. Next, we identified those programs that reported addressing opioid overdose, maternal morbidity, childhood asthma, diabetes, cancer, cardiovascular disease, and mental or behavioral health. These last three conditions, while not SIHIS related, are top reasons for mortality in the state, and that is why we chose to include them. We similarly categorize programs by jurisdiction. Then we juxtapose condition and jurisdiction to determine where programs were deployed and what population groups were served. Next slide. From everything we have learned, we have prepared 4 recommendations. The first is to invest in the infrastructure necessary to standardize the collection of race and ethnicity data across all MDH programs. At this time, which variables are collected, how variables are defined, and whether race or ethnicity data collection is required varies greatly. Part of this infrastructure looks like building an effective communication strategy that can reach all MDH units so as to avoid unnecessary submission deadline extensions, duplicate submissions, and confusion regarding how or why data is collected. Next is a more sophisticated electronic platform or tool for questionnaire submission. In addition to the challenges our team faced, respondents from a number of units as well dealt with complications such as the inability to upload beyond a certain file size or setting glitches that prevented electronic submission altogether. Ideally, we would prefer a tool that can be made available on a web page, provides a data extract that is more user-friendly, perhaps even gives the option for unique login codes to be distributed only to those identified as points of contact for each program. As has already been mentioned, one of the main byproducts of our project has been the start of a comprehensive inventory of programs that target vulnerable populations. We recommend continuing to build this inventory, maintaining it with regular updates, and making it accessible to advocates and other stakeholders by posting it on the state website. Further, as standardization of race and ethnicity data is rolled out, we would also recommend having this inventory set up with features to stratify data by race or ethnicity, jurisdiction, and other relevant options. The last aspect of investing in the infrastructure needed is to reinforce the principle that health equity is the responsibility of all MDH units. Repeatedly, we received feedback from different units that they had no programs serving vulnerable populations, nor programs targeting minority health disparities. But upon continued conversation, we discovered that those programs did indeed exist. Rather, many respondents did not perceive their program in that way. Another example, while 3/4 of the total programs reported collecting race or ethnicity data, only a fraction stated that their program focus was to serve racial or ethnic minorities. Next slide, please. The second recommendation is to investigate tools available for measuring and assessing social determinants of health as they relate to health outcomes. Specifically, garnering a better understanding across state agencies about what tools are already under consideration or are currently being utilized. This will allow for a more complete statewide strategy to promote health equity. The third recommendation is to require the collection of race and ethnicity data in the current Health Occupation Board's licensure or certificate application and renewal processes. This will enable sharing of the racial and ethnic backgrounds of health professionals amongst MDH units, including with the Office of Minority Health and Health Disparities for the annual Healthcare Disparities Report Card. Finally, the fourth recommendation is to collaborate with the new Maryland Commission on Health Equity, which was established with the passing of the Shirley Nathan Pulliam Health Equity Act, also during this past 2021 legislative session. The expertise provided by this commission should guide our work moving forward, including that of the annual Healthcare Disparities Report Card. Next slide. As you have all heard today, we have made a lot of progress. At this juncture, next steps are to share our draft of the report with MDH leadership for approval, which has recently been done. Once any necessary changes are made, MDH and the Office of Minority Health and Health Disparities will submit the finalized report to the General Assembly. But as we mentioned in our recommendations, the work we started with this project can and should be continued. As such, MHCC staff will be shifting our focus back to supporting the development of a statewide health disparities program inventory. When we started this project, in addition to the questionnaire we distributed to organizational units, we also began compiling and synthesizing program summaries for respondents to review. The summaries include information gathered from the questionnaire that was then transformed into approximately 1 page of narrative per program. Our future aim is to use these summaries to build an online interactive inventory. As the mission of the new Maryland Commission on Health Equity is to develop a comprehensive health equity plan to address social determinants of health and set goals for achieving health equity, one of our long-term goals, as mentioned in our recommendations, is to have an ongoing relationship to continue the work we have started. Next slide. Thank you for all of your attention, Commissioners. Tressa, Mariama, and Dr. David Mann from the Office of Minority Health and Health Disparities are all present for this meeting too, and we are all happy to take any questions.
Do we have any questions for Deanna or Teresa or Dr. Mann?
Dr. Pollack.
Commissioner Metz.
Thank you, Diana, for that. Do you guys study or did you look at any other protected class or other areas of disability or other outside of just race and ethnicity?
Yeah, so we did try to keep the questionnaire wording very broad. So that's why we named it vulnerable populations. And we offered for respondents a list of variables that did include things like veteran status. I believe we also included things like age. So we gave folks the option, but how folks chose to respond varied greatly across the program. So we don't have for all 405 programs, we don't have every single one of those variables. It was very much dependent on what the program responded, but we tried to be as inclusive as possible.
Thank you.
Yeah, this is Commissioner Jensen, if I could, Commissioner Pollak.
Of course.
Sorry, I'm muted. Yes, please. Go ahead.
Yep. Appreciate the report and the presentation. It was very, very helpful.
Thank you.
My question is this. We're looking at the healthcare disparities, and my concern or question is this. Most of the approach seems to be on the electronic collection and analysis of data. And my concern is that a significant portion of the population we're trying to analyze would be excluded by that approach. What thought have you given to dealing with those folks who are just not going to be included in that electronic collection of data?
Yeah, well, others on the team are welcome to answer too, but one of the things that we did include in that variables list that I just mentioned was bandwidth and Wi-Fi access, just to even get an idea of programs that were already looking into that as an issue. We also did ask programs to list any limitations such as those for their program implementation or outcomes, performance, etc. I just would like to say that this was really an initial step. And so that's sort of what we're reporting on today, but it looks like Dr. David Mann has more.
Dr. Mann, go ahead.
Yeah, I think the electronic data collection that we're thinking of is probably more at the time that people interact with programs and the program does data collection during that interaction. How does that become electronically available for use? It's probably not as much trying to get people to kind of from their home based on their own IT connectivity, try to submit data to us, because I think would have really big problems for the fact that the digital divide is so great for different disadvantaged populations. And I think the issue about other protected classes besides race, ethnicity gets to whether we even have data systems that collect the identifiers for those other groups in our healthcare data collection systems, because oftentimes the only things we really can stratify health outcome data by are things like age, sex, race, ethnicity when we have that, and geography. And there's more levels we'd like to have, but we've got to have those identifiers in those databases.
I absolutely, agree. You've got to start someplace, and this is a good place to start. I think that it's worth taking a look at the step before people interact with the healthcare system, because disparities in healthcare may actually prevent people from interacting with the healthcare system, which would prevent them from being in the data that you're collecting there. And I'm wondering if you've given any thought to, at some point, reaching out to people in these communities and asking them what would be the best way to communicate with them and get information about them.
Right. So trying to understand the optimal communication methodologies is something we'd be interested in getting, and whether that, I guess the question becomes whether that's something that healthcare systems would try to initiate, whether MDH should try to initiate that. We have to figure out who would then have the infrastructure to do that kind of a surveillance system or data collection system. So that would certainly be something to think about. The upcoming Health Equity Commission is really focused on a health and all policies kind of approach, because it really has members from all of the executive cabinet agencies, and I think is really going to be focusing on, and I think the data set that's being asked to be created as part of that bill is going to be focused on how do we merge social determinant of health data into the health and mix that with health outcome data and figure out how those social determinants impact health outcomes and how prevalent certain ones are in Maryland and in particular places in Maryland, so that we can really try to get upstream of the whole process and really get to some of the primary prevention of disparities that we'd like to be able to do.
Thank you. Additional questions?
I have one. I know the best is the enemy of the good. So, right. So you can argue about the best way to cut relic data, like until the cows come home, and you have to someday have a standard that can be implemented universally. But I am concerned that we seem to rely on like the same 5 categories that were defined like decades ago. Like, how do we address within some of those categories? For example, if you look at like Asian, like encompasses, I'm not sure what percentage of the world's population that is, but folks that described as Asian, I think it's more than 50%, right? All lumped into one category. How do we, are we thinking as we go forward in this, how do we best figure out subpopulations within these categories that may be really important or having very different experiences, things like that?
Yeah, that's a great question. We also had very similar concerns. And so we asked respondents to also define how their variables are broken down, what sort of groupings they're using. We did not want to assume that they are using the same sort of 5 racial or ethnic categories. And so we were able to get some respondents feedback in terms of some differences they're using, but I think that's part of why we're also making the recommendation to include some standardization so that we can even start making those kinds of recommendations, right? To look beyond sort of fixed groups that have been proven now to not be necessarily all encompassing. I see Ben and both Dr. Mann have hands.
Yeah, Dr. Mann, did you have a response, or are you just leaving with your hand still up from before?
Well, no, just on the collecting groups, we were using the 5 groups that are specified by the federal OMB Directive 15, which kind of standardizes really large kind of macro data collection. It doesn't get to all the micro subdivisions that might be important. The tricky part is eventually you get to subdivisions that are so small that it becomes nothing but unreportable data. And so I think one of the things we'll have to think about is which subgroups of which groups have large enough populations in Maryland for doing that subdivision to be useful, and then building that back into the data collection systems. Because I can't tell you about the Ecuadorians or the Vietnamese if that's not collected in the death certificate or in the HSCRC data set or places like that.
Ben?
So this is a administrative point in that this report was to be done by the Office of Minority Health and Health Disparities in consultation with MHCC. So theoretically, the department is the lead on this. We're not sharing the report yet because we do want to share it with the secretary. What we try to do is bring this report back to the commission for you to have a chance to read it before it goes to the legislature. As Deanna outlined, it was a Herculean effort to gather this information, and a lot of time was lost simply because of the challenges in data collection. So we're going to try to do all that. The secretary has first bite at the report, however, but we want to make it available to the commissioners as soon as we possibly can after he conducts his review. Such is the nature of collaboration.
Thank you. Other comments or questions? Deanna, thank you.
Thank you so much.
Next up is the beginning of the Tracy DeShields show. As you may recall, legislation on advanced directives was introduced in the 2021 legislative session. It would have required a carrier to offer electronic advanced directive forms to its members and dependents. This bill did not pass, but interest remains strong in promoting advanced directives. MHCC was asked by HGO to form a work group to develop compromise recommendations on the promotion of advanced directives that could be considered in the 2022 session. Tracy DeShields, Director of Policy Development and External Affairs, will review the recommendations developed by the Advanced Directives Work Group. Tracy, the airwaves are yours.
Thank you. Next slide, please. So As the chair mentioned, good afternoon, everybody. There was legislation that was introduced, and that legislation did not pass, and MHCC was asked if we would convene a work group. We did do that. The work group consisted of over about 40 stakeholders representing advocates, medical care providers, representatives from nursing home, hospice, and palliative care communities, as well as commercial insurers, technology vendors. We also had representatives from the Insurance Administration and the Department of Transportation, as well as legislative staff, and of course, Senator Ben Kramer and Delegate Bonnie Cullison also participated in the work groups and provided leadership. So to all of those folks, we do extend our tremendous thank you to them for all the work that they did on the work group and for us to come up with the recommendations. So the work group did come up with 4 recommendations. I'm just going to go through the recommendations now. So the first recommendation is with regard to actions by insurance carriers to collect healthcare agent information and increase the promotion of advanced directives. So essentially, the work group recommends that insurers place a link, if you will, that is easily accessible in an easily accessible location on their website portal to a healthcare agent registry. And this registry would be operated through CRISP. They can currently set something up to do that relatively easily. Registry for consumers to identify a particular healthcare agent that would have some knowledge of their health status and maybe their health wishes in the case of an emergency or end of life situation. And also there would be the option for them to complete an advance directive. Now they would be directed to a different site in order to complete the healthcare, the complete advanced care document. Let's see, so recommend next slide, please. Bear with me just a second here. Let's see. Recommendation 2 involves actions by providers to collect healthcare agent information and also promote the completion of advanced directives. Nearly all participants on the work group support the uploading or entering advanced directives and the identification of a healthcare agent through an electronic health record at the time that the patient comes in to register. There's an easy way for that to be entered into a healthcare provider's workflow. And the leading EHR vendors operating in Maryland do already include advanced directive modals for the collection and storage of this information. So the work group did feel that providers have an important role to play in increasing consumer awareness and the use of advanced directives, as well as providing, helping them understand the importance of having a named healthcare agent, if you will. Next slide, please. Okay, recommendation number 3 is actually related to actions by health information exchanges, in particular, connecting nursing homes to CRISP. The work group recommends that nursing homes in Maryland integrate with CRISP. Two vendors account for about 90% of nursing homes statewide. Integration will allow nursing homes to capture advanced directives and/or healthcare agent information in the patient care workflow. So actually, this recommendation is in line with the integration that would happen under House Bill 1022. And then the last recommendation, recommendation number 4, next slide, please, proposes the development of a pilot project for ambulatory practices in health system. So the thought here is MHCC would establish a pilot project for ambulatory practices in health systems. WellSpan, which is located in Pennsylvania, actually did a pilot, and now it's a permanent program under that WellSpan system. It was called the WellSpan Advanced Care Planning Initiative, and WellSpan initiative successfully implemented team-based advanced care planning processes within their primary care practices, which coordinate or are affiliated with the larger healthcare system, so the hospital and the ambulatory care systems within WellSpan. Our project would be an adapted version of the WellSpan initiative. The goal would be to improve the collection of healthcare agent information and advanced care and advanced directives. So right now, we would have to flush this out a little bit. Funding source would need to be identified in order to incentivize this pilot. But one of the ideas would be to do the pilot through the Maryland primary care program. So those were the 4 recommendations from the work group. The work group also, in addition to the 4 recommendations, recognized the need for continued public education around the importance of having advanced directives and a named healthcare agent. So they really felt that in addition to these, there really needs to be a concerted campaign effort on just about every level, if you will, to normalize conversations and people's understanding about advanced directives and healthcare agents. So unless I'm happy to answer any questions, and on answering questions, I will also enlist Ben and David.
Mr. Jensen, you have a question for Tracy?
I do. Just questioning, I'm just curious, who are the members, not list of all of them, but did the people in this work group include folks in the healthcare systems who are pursuing these kinds of projects internally?
We did have, geez, I don't know really how to answer that. I don't know if they're necessarily pursuing it, but there are people, there were groups involved who currently are doing this. So there was Horizon Foundation, they're an advocacy group, and they're doing work in this space. We do know we didn't have, I mean, if you're talking about like University of Maryland or Hopkins, I don't know that we had a specific representative.
I know that the MedStar Institute for Quality Improvement has done extensive work in this area, so it just might be worth reaching out to them. So my only thought.
Right, got it.
If they weren't, it wasn't a trick question. I wasn't sure if they were in your work, and if they're not, it's worth reaching out to them. That's all.
Got it. Ben?
So we didn't specifically ask for representatives from health systems, but they were represented. It's probably noteworthy that we did have a number of people that are staunch advocates from on advanced directives and advanced care planning generally. Dr. Morheim and other representative physicians who see the challenges faced in the ED and other care settings when advanced directives are not there. I know we probably don't have time to talk about this today, but David Sharp has had extensive discussions with each of the major health systems, academic and MedStar, about what they're doing with regard to advanced directives. We've come up on a kind of a starting result, which is that the Epic, the health systems that are using Epic seem to be farther along in the gathering of electronic advanced directives through their EHR than the Cerner products, not necessarily because Cerner doesn't have it, but because the systems that are using Cerner aren't quite as interested, and that's going to be one of our major engagement efforts. David and his team, Nikki Majewski in particular, should be lauded because they've worked with some of the systems to try to figure out why, when an EHR vendor says, yep, we have it, and show us that, then when we go on that system's portal, patient portal through the EHR, it doesn't appear. And we're working through that slowly, but there are a number of different hurdles we have to take on.
Thank you, Ben. Before we go on, could I ask whoever is at 43768-4400 to please mute your phone? Thank you. Other questions for Tracy?
I just want to make a note. The people involved in the work group were specifically, a lot of them were those that weighed in on the legislation during the legislative session. And that would, unless there were any other questions, that's all I had for this particular presentation.
Thank you, Tracy. Next up, it's still Tracy to provide an update on the upcoming legislative session, including an overview of the general legislative process, some important dates for us, and our role as a commission during the session. Tracy?
Okay. So yes, so the legislative session starts, will be starting beginning January 12th, 2022. I have 2021. That's not right. Next slide, please. And so this session will be, it's 90 days. It goes from January until the first week in April. This year would end around April 11th. So it's usually we mark it by when Easter falls. So I think Easter is earlier this year. And just generally some background, there are a total of 148 members in the General Assembly, 47 in the Senate, 141 in the House. You have odd numbers for obvious reasons, tiebreakers, that sort of thing. And just a fun fact, between 2016 and 2020, the number of bills introduced averaged over 1,100 in the Senate and about 1,600 in the House of Delegates. Not all of those bills passed, probably less than 25% actually do pass and are signed off by the governor to become law. So, which is kind of interesting, but that was just kind of a little fun fact. Next slide, please. So some of this, a lot of you may already know, but for our new commissioners, the key committees that MHCC is usually before In the Senate, it's Senate Finance Committee. Most of the bills that would impact us would go before that committee, and we would present testimony or position statements, written testimony or verbal testimony to that committee. The budget would be before the Budget and Taxation Committee. And our budgets are not done singularly, but with what they call the regulatory commissions and the regulatory boards, the licensing boards. So our budgets are usually presented collectively. In the House of Delegates, we are before the House and Government Operations Committee. And again, most of the legislation that we would be weighing in on would go before that committee. And again, our budget on the House side goes through the Appropriations Committee. Now, there are other committees that there may be pieces of legislation before committee that normally were not before. So that does come up, such as maybe Ways and Means. On the Senate side, it could be the Education, Health, and Education, Health, and Administration Committee. So there's, so we could go before all the committees on either the House side or the Senate side, but it's likely the committees we're going to be before would be Senate Finance, Budget and Taxation, Health, Government and Operations, and the Appropriations Committee. Next slide, please. So dates of interest, or really important dates. January is a big month. Bills start to become introduced. We'll start to see those bills, and discussions will begin on some bills that are being what they call introduced into the House or the Senate. And there is a certain period, there's a cutoff date in January. So this year, which I think it's around January 15th, where it's called the guarantee date. And that means that your bill will be able to be introduced without having to go to the Rules Committee. So it's a quick date, it comes up pretty fast. And then there are what they call introduction dates, in which it has to be assigned to a committee, introduced in the House and introduced in the Senate and assigned to a committee. And those dates this year fall on February 7th and March 7th. And then if we miss those dates, then we have to go to the Rules Committee, and it just becomes a dragged out process for your bill. So nobody really likes to land there. It's it can be purgatory in some regards. By the middle of March, March 21st, any legislation that has been introduced in either the House or the Senate has to cross over into the opposite House. So in other words, if a bill was introduced in the House, it has to be in the Senate before March 21st. Again, if it falls outside of that date, you land in the Rules Committee. And at that point, it's pretty late in the session, so it's not likely that the bill will come out of the Rules Committee. If it does come out of the Rules Committee, it's likely that it's not going to be brought up for a hearing in the committee, and it will just fail for this particular legislative session. Important for the governor and for the state as a whole, the budget bill has to be passed by April 4th. So it has to be passed by the 83rd day of the legislative session. The budget this year will be introduced on January 19th. That's a whole long separate sort of process from the traditional legislative process, the budget process, but they kind of run parallel. So this year it should be pretty interesting, given the fact that we seemingly have a lot of money in the state coffers. Sine die, which means the last day of the legislative session is April 11th this year. It's Monday, April 11th. Everyone sort of looks forward to that, but up until you get to that point, you're grinding all the way in. But anyway, next slide, please. Okay. All right, okay, so for us, I'll just go over this really quickly. MHCC dates of interest, really this year, these are just general timelines for us. We will start to have conversations with the commissioners. There will be a scheduled weekly call with the commissioners to talk about bills and recommended positions on legislation. With the commissioners, and then from there we'll decide whether or not we can firm up any recommended positions and what testimony or language will be presented to the legislative commissions. January and February are usually busy one with briefings on different topics. No one's reached out to us yet about a briefing, but I wouldn't be surprised if we are asked to participate in a briefing on something or other. I don't know what that might be. It could be anything. And also bill hearings. So those will happen this year. We're not exactly sure how that's going to flush out, and I'll talk about that a little later in my presentation. Essentially, with regard to, next slide, please. How does MHCC fit in to sort of this whole legislative process? Well, a number of ways. One, you will assist staff in coming up with positions and directions to take on various pieces of legislation which might impact us, our work, or our scope, if you will. But one of the things about MHCC is that you are considered a trusted source, a trusted steward for the legislature and for the executive branch as well. So one of your roles is one, I apologize. I'm going to mute for a second.
He apparently didn't like something you had to say.
My dog is very interested though.
My doorbell rang, and so of course the dog is in the same room, and he apparently has an opinion. Okay.
Send him to the legislature.
One of the nice things about COVID is that people all realize that these things happen now.
Yeah.
Okay, I think we might be okay now. Anyway, so the role is, one, you educate legislators about MHCC, our role, responsibilities, its relationship building. We can suggest legislation. One of those is bill that we will have this session on health information exchange. We explain MHCC budget requests, review relevant bills and positions, and provide information in areas of expertise in response to requests from legislators. So we do play a significant part in the legislative session. Next slide, please. And then during the legislative session, you will be helping to direct development of positions on bills that we'll take. you'll work with us. As I said, we'll have probably weekly meetings. Those meetings may not necessarily be consistent weekly because we may not have any bills up for a bill hearing that we would need to discuss during a certain time frame. And then next slide, please. I'm not going to really go through this, but this is just a diagram showing how legislation and everything like that would be developed. Just a chart just to show sort of the flow. You know, during the legislative session, we will identify a bill, the position development by staff. That recommendation will be made to you, and then it's reviewed by Ben, and then that information is then relayed to you as the commissioners. I apologize. I'm just going to keep talking. Sorry. He didn't like that, I guess. And then
So maybe
finalize.
So maybe I'll finish, Tracy.
Okay, that's fine. Thank you.
So the sharing with the executive branch actually means that coordination with the Department of Health and then sign off by the governor's legislative office before it goes to the legislature. Those two elements are actually can be rather prolonged. The reason we share with the department is the department wants to come in with one voice. The Healthcare Commission and HSCRC are a little different, and consequently, there are instances where our positions diverge, but they want to know about it first. And often when they do diverge, it's punted up to the governor's legislative office for resolution. The Hogan administration runs a pretty tight ship on legislation relative to, say, the O'Malley administration, in part because they're the executive branch of a different party, and they recognize that positions and legislative initiatives that they are interested in may not be supported by the legislative body. So they try to be as tightly coordinated as possible before it gets to the legislature. Do you want me to pass it back to you, Tracy?
Yes, you can.
Okay, go ahead.
Next slide, please. Okay. Okay, so getting back to, so some of the legislative priorities this year, certainly the budget, there's a $2.5 billion budget surplus. There actually may be a little more money in that. So there will be a concerted effort by the governor to hold the legislature to, not passing long-term mandates that require funding, because the outlook, they try to do, take the budget in 5-year increments and expand out, but they actually do a 10-year expansion. So while the budget probably looks really good for the first 5 years, it does tighten up as you get past 2027, I believe it is, or 2028. And so with that in mind, you don't want to have a lot of long-term mandates that at the end of the day, the state cannot fund, or essentially has to modify funding efforts around. Education funding, I think, will come up again. It comes up every single year. And the governor, I think they passed his emergency crime bills during the special session, but I have a feeling that they may likely come up again in a different form. In other words, there may be some other legislative pieces that may come up. That was a big thing a few months ago. As you know, I think last month the governor went into Baltimore and had a press conference about what is going on there. Abortion rights will be on the table this year, as well as probably suggestions around some forms of tax relief. Not exactly sure what that may entail, but I do know that there is interest in that. And then, of course, coronavirus remains on the table. As well, for MHCC specifically, that we probably will be looking out for is maybe any potential legislation around nursing home acquisitions, telehealth, assisted living studies, cybersecurity will certainly probably come up this year. There is a cybersecurity task force that has been in place, and I believe they will definitely have legislation this year as well. Next slide. And then how session will function this year is going to be interesting. Both the House and the Senate will allow, their buildings will be open. Last session, the buildings were closed to the public, but this year they will be closed. I mean, they will be open to the public, but I think in a controlled way. In other words, people can't just loiter. You have to have a purpose for going in and out of the buildings. But I think if you're just a member of the general public, they probably aren't going to say very much other than maybe wear a mask. If that is in place, I think it will be. I do know that the House of Delegates has issued their protocols for the legislative session, and their committee and subcommittee will meet virtually, so they will not be in person. They will live stream those, and then essentially they will operate the same way. So witnesses will need to be signed up 2 days before a bill hearing. So the timelines for everything for us is not like on every day we can do something and submit something. It has to actually be ahead of schedule, a lot, 2 to 3 days ahead of when there's a scheduled bill hearing. Your position statements have to be in, your witnesses have to be signed up. Bill hearings will start January 13th. Prior to that, like usually on the 12th, they'll probably have briefings that day. With regard to the House chambers, in the State House, they will be open. However, seating will be limited. And so it's on a first come, first served basis. But I believe the floor proceedings will be live streamed like they have been in the past prior to COVID and during COVID. And then the Senate, what I've heard, and I don't know that this is 100% accurate. I need to follow up with maybe Senate staff and ask this if they have come up with their protocols yet. What I had heard is that they would be in person for bill hearings and for the committee as well as subcommittee hearings as well. And of course, the Senate will be open similarly to the House gallery as well. So the Senate's smaller, so there's limited seating anyway. So it's always on a first come, first served basis. And I do believe that they will be live streaming the floor action. So I apologize for my dog interruption and the doorbell ringing. Life kind of happens. And so that's what I have for my presentation. And thank you very much. Happy holidays. Last slide, please. Next slide.
Hi, are there questions for Tracy? My dog was barking. I had to. My dog doesn't listen as well as yours does.
Thank you.
All right. Thank you, Tracy.
You're welcome.
Ben, would you like to share an overview of upcoming activities?
So I'm going to, first of all, want to wish the commissioners all happy holidays. We will likely be sending you a couple of communications over the next several days. One is the a somewhat longer strategic priorities update, and we'll get you the disparities report. We may bring that back for a formal vote in January. On the January meeting, we'll also be providing you with, I think we have one CON, just a note on several longstanding contested cases, certificates of need. We are moving forward with those. One is the organ transplant, the kidney organ transplant review. The second is a children's hospital. We can't say definitively if they will be in January or later, but they are moving ahead. As most of the commissioners know, contested cases are quite complex. The third item that I wanted to let everyone know is that we had planned to release our practitioner expenditure report at this session, but there is a lot of interest in how Maryland fee levels, practitioner fee levels compare to fee levels in the rest of the country. I've asked staff to take a more thorough look at those and work with some of the national studies that have come out over the last several months, in particular, the one by Robert Berenson and his colleague, Mary Jo Braids at the Urban Institute. We're going to try to mimic that as closely as we can in the results. So it's very likely that that report will not be available for presentation to the commission until February. But in the interest of benchmarking fee levels to some of the national results, I think it's worth the additional time. And as we move through next week, I too will have an update on more certainty on what the January agenda is going to look like. Typically, January is a little lighter, given that our December meeting is quite long, but some of the reports that we presented, overviews for, could come back in January for just final chance for commissioners to comment on. So that's all I have for today. I want to recognize in particular the work of the Disparities Study Group that included Dr. Braithwaite and Dr. Mann from the department, as well as Teresa Lee's entire team to get that done. It was, as I said, quite an effort in the midst of the pandemic, gathering information, but I think it's an important first step, consistent with what we've talked about. I think the legislature will be looking at all programs through the prism of health equity. So position that in the commission in this key area, I think is going to be really important. Thank you.
Thank you, Ben. I want to wish all the commissioners and their families a Merry Christmas and a happy, healthy New Year. And with that, I'll accept the motion to adjourn.
So moved.
I'll second.
Commissioner Boyle, second. Commissioner Sargent, all in favor?
Aye.
Happy holidays.
Have a great holiday, everybody.